Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ free 2-week session. So, as you can find out from our First Aid AMC MCQ group, that we have taken our trial class on 24th of September, and we did a psychiatry trial class. I hope that you guys enjoyed that session. So tonight we are going to focus on question solvation. Question solve is a very integrated part of your AMC MCQ preparation. You need to make sure that you have enough theory knowledge and you have to implement that knowledge to solve questions. So when you start your preparation, you will understand that you will be giving a good amount of time just to solve questions, especially questions from previous years. Those questions are always important. Now, the part of the course is to help you to solve these questions so that you understand the common important topics that can come in your exam. Now, why we do this question solve? It's not for you to memorize the answer of these questions, because these questions are just you can say, just a fragment of the questions that can come in your exam. And the main reason why we do the question solve is to understand the important topics. So you need to know each and everything about the topic from which we are doing the question solve. And please never ever try to memorize the answer, because any kind of questions can come in your exam. If you have good knowledge on a particular topic, you can correct that answer in any way. So how difficult the topic comes in your exam, that will not matter if you have a good knowledge on that topic. So the main thing is for you to understand the topic and what to learn from a topic. When let's say you have come across a question which is asking about, let's say, pneumothorax. What you really need to know about pneumothorax is what is actually pneumothorax, what is the main presentation of a pneumothorax patient, that means what is the most common symptom, what is the most common signs, and then what will be the examination findings. Then you need to know the investigation and management. This is the tricky part. In investigation, you need to know that what is the initial investigation for this kind of patient and what is your best investigation for your patient. So in your exam, the last line is important. Whatever they are asking, you need to know that are they asking for the initial or next investigation, or are they asking about the best investigation? Because the answer will be different based on what they're asking. And also you need to know the initial and best management of that topic. So that's how you should learn each topic that you are reading. It's not about reading and retaining every information about a topic. It's more about being a smart reader. So a lot of candidates will just read and read. They will memorize each and everything. But at the end, everything will become like too complicated, and that candidate usually will not be able to retain the most important part of that topic. Whereas if you know how to read smartly, you will retain the information that you only need for this exam, nothing else. Okay? So tonight we are going to show you these tips of solving questions. That means how to read a question properly and how to extract information from a question and what are the traps in a question. Not everything given in a question is for you to answer the question. There are some information which is just to make you confused. So you need to know what are the tips in a question to solve that question, and what is the trap and how the examiner is trying to confuse you. That also you need to know from that question. So we will show you some questions which are very, very important for your exam, and we will discuss a little bit about the topic. Always remember, our question solve classes are mainly focused on question solve only, not going too much detail about that theory, because you will get the theory classes with us and we will discuss the theory in a very detailed way in that class. So question solve, we mainly show you how we are coming into that answer, and we might give you some reference to make it strong so that you feel confident to answer that kind of question. And the detailed discussion of that particular topic will be done in a theory class. Okay, so let's start. So this is your first question: diabetic patient with a food ulcer. And yes, this class will be recorded. So if any of you can't join the class, or if you miss the class, or somehow you need to just get out of the class, maybe at the middle of this session, then you can get the recordings. That's totally fine. So diabetic patient. So you've got a diabetic patient with ulcer on the right foot. There is two picture given. So two deep ulcer at the medial malleolus and also on the foot with skin necrosis and inflammation. So diabetic patient foot ulcer, two ulcer, one on the medial malleolus, another on the foot. The HbA1c is 6.5. So HbA1c normal value, it's usually if it is between 6.5 to 7.5 in a diabetic patient, we are happy with that. That means diabetes is still well controlled. So diabetes is not too bad in this patient. He was admitted and antibiotic was given. And also you have taken swab, send it for culture and sensitivity. What will you do after that? So what I said is that first thing you notice that what is the question asking? So they're asking the next step, right? What do you want to do after that? So not the best step, they're asking the next step. So what you want to do in a diabetic patient who has got a 2-foot ulcer with skin necrosis and inflammation, antibiotic given, swab has been already taken. Do you want to do an X-ray, MRI, bone scan, Doppler ultrasound, or a complete blood count? So what do you think? X-ray. So you want to go with X-ray, not MRI, not bone scan, not Doppler or CBC. Very good. Okay, let's discuss a little bit. So this is the ulcer that we are talking about. So you can see that this patient has got a foot ulcer, right? Now, diabetic foot infection, it has a stage. And we divide the diabetic foot infection into mild, moderate, and severe. So when there is sign of inflammation, we are worried that diabetic patient might get infection because they are very prone to get infection. So we are always worried in a diabetic foot ulcer that they can get infected. How we know it is infected? You can get some slough on the top of the ulcer. You can get discharge, and sometimes also sign of inflammation can be there. But how we know that is it a mild, moderate, or severe diabetic foot infection? So mild means that it's just a local infection involving the skin or subcutaneous tissue. So it doesn't involve the deeper tissue. It doesn't show any sign of systemic illness, like no fever, tachycardia, nothing like that. The surrounding redness or erythema around the wound should be less than 2 centimeters. So this is mild. Moderate, when there is surrounding redness around the wound more than 2 centimeters or involving the deeper structure, but still there is no sign of systemic illness, which means no fever, no tachycardia, no systemic symptoms. That's moderate. When a patient with moderate symptom has systemic symptoms, it becomes a severe diabetic foot infection. So why we need to know about it? Because many times they ask you the management of diabetic foot infection, very commonly asked. So that's why we need to know if it is a mild, moderate, or severe foot infection. Next part is about the main thing that you need to retain for this diabetic foot infection. If a patient has got diabetic foot and then there is a non-healing ulcer, at least for 2 weeks, then we are concerned that if this infection can reach into the bone, causing osteomyelitis. So the next or initial investigation in such case is X-ray of the foot. Although X-ray most of the time it cannot diagnose osteomyelitis, But in severe cases, sometimes it can show destruction of the bone, which can be suggestive of osteomyelitis. But what is the most appropriate or best investigation in this case? That will be your MRI scan. If MRI is not available, then we can do a bone scan. So any of these MRI or bone scan is the most appropriate investigation for osteomyelitis. Okay, so if a diabetic foot with non-healing ulcer for 2 weeks, this will be our step-by-step. If there is a diabetic foot, but you can see yellowish discharge coming from the wound, that means it is an infection. In that case, obviously, we will start with taking a wound swab, just like the question has done already. You take a wound swab, send it to the lab for microscopic culture. You do the debridement of the wound, so you clean the wound properly and start the patient with antibiotic. So that will be your initial step before thinking about X-ray or MRI. Okay. Now, if you come back to this question, you can see that this patient has got diabetic foot ulcer and patient has been admitted, swab has been taken, antibiotic has been started. So that means they have already treated the infection. Okay, so what we need to rule out now. At the moment, the main thing that we want to rule out is the possibility of osteomyelitis. In exam, they usually give you a little bit more detailed information, like how long is the ulcer is there. So most likely you will get a non-healing ulcer, like maybe this patient has got this ulcer for 4 weeks. So in such case, your initial investigation will be X-ray, as most of you also thought. So very good for that. If X-ray is non-suggestive, but you are concerned about osteomyelitis, then you would go for MRI or bone scan. Okay. Now, if you think that this patient has got a diabetic foot infection, what will be your choice of antibiotic? So if it is a mild infection, so now you know what is mild, moderate, and severe, right? So if it is a mild one, then you can try with any oral, like oral amoxiclav, which is amoxicillin and clavulanic acid. You can try cefalexin, flucloxacillin, or clindamycin. If patient is allergic to penicillin, you can't use any of this, amoxicillin, flucloxacillin. Sometimes we can use cefalexin in a patient who has penicillin allergy, especially if they haven't got any anaphylaxis. If they have got a delayed rash or delayed allergic reaction to penicillin, we can still use cefalexin, but the best option in those cases would be clindamycin. So penicillin allergic patient will get clindamycin. If patient is not allergic to penicillin, then best would be amoxiclav. For moderate infection, usually we would go for IV augmentin plus metronidazole. For severe, you have to cover the gram-negative organisms, which means you have to try either pip-taz, which is piperacillin tazobactam. You can try sulbactam, clavulanic acid, or maybe a ciprofloxacin. So any of these antibiotics can be tried. So this name of the antibiotics come in exam very commonly. So it's very important to know about it. Okay. So this is a guideline from Australian Diagnostic Imaging Pathway. So diagnostic imaging pathway is one of the guidelines. It shows some step-by-step approach of different scenarios. So I would always suggest that if you're looking for a step-by-step approach, then go for these diagnostic imaging pathways and just have a look at what is the step-by-step approach. Like in this case, patient has got diabetic ulcer. They have started with a plain X-ray. Then they are looking for if there is any sign of osteomyelitis. If yes, then consider bone biopsy and treat osteomyelitis. If there is no sign of osteomyelitis in the X-ray, then you can do two things. Bone on view. Can you see the bone? Like in the naked eye, can you see the bone through the wound? Or if you use a probe, can you touch the bone with the probe? So this is called positive probe to bone. If any of this is there, then there is still a likelihood of osteomyelitis. In that case, you can consider a bone biopsy and then treat as osteomyelitis. Now, if there is no bone on naked eye, you can't even feel the bone by the probe. In that case, are you still highly suspicious of osteomyelitis? If no, then you can do a repeat X-ray in 2 weeks. If yes, then you can go for MRI. If MRI is unavailable, then nuclear medicine scan, which is the bone scan. Okay, see that this is the step that actually AMC wants to know from you. So you have to know this step-by-step approach because question can come from anywhere from this chart. Okay, any question with diabetic foot infection, guys? How sensitive is X-ray for osteomyelitis? Very less sensitive, but still as our initial investigation, we will do that. We will never go for MRI directly unless we are actually sure that this is an osteomyelitis case. Like if there is bone to, if the probe can go into the bone, that's osteomyelitis likelihood. In that case, yes, we can go directly for MRI. But if there is no suggestion of osteomyelitis, X-ray will be our initial investigation. Okay, so good question. Why not Doppler? The main thing is that Doppler is going to help us with the management anyway. This is a diabetic foot ulcer. Doppler, we would be doing it either to know that if this patient has got peripheral vascular disease or if this patient has got a venous ulcer, right? Now, the main part in this case is that there is nothing indicating in here that this patient is suffering from peripheral vascular disease. Rather, it's more towards diabetes. Although diabetes patient can have PVD, but still, at this point, what is more important to know? Is it more important to know that if this patient has got osteomyelitis, or is it important to know that if this patient has got underlying or any associated PVT or venous problem? Okay, so that's the main part. Now, we might be thinking that if there was no other option, so options sometimes also important. They have given you options of X-ray, MRI, bone scan. Even by looking at the option, you know that the examiner is thinking about osteomyelitis, right? Because you would not do any of these others if you're just thinking about a PVD. So sometimes we also try to think that what examiner is thinking before writing this question. Okay. Now, as part of the management, we can always do a Doppler in this patient later on, but we always need to think step by step. What is the next thing in a diabetic foot ulcer? First, if there is any infection, treat the infection. Then, if there is infection, then does the infection has any possibility of going into the bone? That's why we rule out osteomyelitis. So the main important thing are coming first, and then gradually we can go more and more deeper. Okay. That's a good question, Dr. Rabia. If bone is visible, then no, we don't need to go for X-ray. We will directly go for MRI or bone biopsy. I would start with a MRI or a bone scan before going for bone biopsy. Okay. Now, in between MRI and bone scan, what is preferable? Now, most of the time, bone scan will be difficult to get. So it always depends on the availability. If in the question you have got both MRI or bone scan, we would go for MRI first. Okay, just you can see here, according to the chart, that first of all, if you will do MRI, if MRI contraindicated or unavailable, then we do a bone scan. Okay. And venous insufficiency, Dr. Iman. So venous insufficiency ulcer will be looking like most of the time that's a wet and there will be a lot of exudates. This ulcer, the diabetic ulcer in here, you can see there is not too much of the exudates, but the main part of the venous ulcer is that there will be a lot of pigmentation around it. There will be hemosiderin deposition. It will look very gross, edematous, swollen, and sometimes even lots of exudates are coming out. Patient might also give you symptoms of varicose veins positive in this patient. Okay, so there is no hint for venous insufficiency in this patient anyway. All good. Let's move on to the next question. A young man working came to the emergency department with big abscess under the arm. After draining the abscess, what is the investigation of choice? So a young man working came to the emergency department with a big abscess under the arm. After draining the abscess, what is the investigation of choice? Antibiotic, full blood count, wound culture, ultrasound of the drained abscess, CT scan of the arm. So what will you do in a patient who has got a big abscess? So I can see you're mainly confused about antibiotic and wound culture. The question is that if you give antibiotic first, then later on if you do a wound culture, is it going to help? No, because you have to send the abscess, or you have to take the swab first before starting the antibiotic in a patient. Why? Because if you have given the antibiotic, most of the time you can't even get the bacteria that's causing this abscess. Okay? And why it is important that, let's say you will start a empirical antibiotic, and that empirical antibiotic might not be sensitive to the bacteria that's causing this infection. So if you can't find out the organism, you can't treat it properly. So that's why every time if you have got an abscess, especially big abscess, you start the antibiotic, but you start the antibiotic after taking the culture. So you do the incision and drainage, you take the swab for culture, and then start the antibiotic. Okay, you don't need to wait for the own culture to show the bacteria. So you will start with just a general antibiotic. For abscess, what's your most common antibiotic that we give? Flucloxacillin or dicloxacillin. So you will start with that, and then you will wait for the culture result to come back. Okay, so own culture will be your next step. And the other, full blood count, is not going to help your management anyway. This patient will obviously get sign of infection, like WBC will be high, so it will not cause any difference in your management. Ultrasound of the drain abscess. If you have already drained the abscess, what's the role of doing an ultrasound or a CT scan? Nothing. Yeah, cefalexin can be given also, but ideally for abscess, you start with either dicloxacillin or flucloxacillin, that's your initial, or sometimes cefalexin. Any of these two is fine. Not augmentin in Australia. In Australia, for abscess, our first option of antibiotic would be either penicillin, which is fluclox or diclox, or cefalex. Next question. So, a previously fit 55-year-old man has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. Now, this is a very tricky question. 55-year-old emergency hemicolectomy for a perforated cecal cancer. 2 days after the operation, you note that there is following is the patient's fluid balance chart. So you have given intravenous input of 2 liter. So patient's input is 2 liter. Now you will find out the output. Nasogastric aspiration, that's output. So output to drain loss is 700 ml. Then urine output 500 ml. Right? So any kind of output, if you are measuring, we always add another extra 500 ml. Why? Because many times there are some loss which you can't measure. So from the skin evaporation, so there are some insensible loss which you can't measure. So you add extra 500 to that. So how much it comes? So 3700 ml. Just make it whole. So make it 4 liter. It will be easy to do the math. Okay. So input is 2 liter. Output is 4 liter. So what is higher, input or output? Output is higher. So that means patient is losing more fluid rather than having a good input. Now, biochemistry shows sodium 135, potassium 3. So potassium is a bit low. Chloride 100, bicarbonate 27. Which of the following fluid balance regimen would you order for the next 24-hour period? So this is a very typical question, which is mainly post-operative surgical fluid balance chart. So how we measure that? So we say that every patient, especially every post-operative patient, will get a maintenance fluid. The maintenance fluid will be like this. 1 ml normal, sorry, not ml, 1 liter normal saline plus 2 liter dextrose plus 20 milliequivalent potassium per liter. So 1 liter normal saline, 2 liter dextrose plus 20 milliequivalent potassium per liter of fluid that you are giving to the patient. So this is the normal maintenance fluid for every post-operative patient. Now, this patient, the patient that you have got, you can see in here that patient's input is 2 liter and output is 4 liter. So what is the deficit of fluid in this patient? 2 liter, right? Because 4 liter minus 2 liter is 2 liter. So 2 liter deficit, that extra deficit amount you have to add in the normal saline. So with 1 liter normal saline, now you are adding 2 liter normal saline. So it becomes 3 liter normal saline and the dextrose remains the same. Now, how much fluid you are giving to this patient in 24 hours, guys? 5 liter. Very good, Dr. Jina. So we said 20 milliequivalent potassium in every liter of fluid you are giving. So if you're giving 5 liter of fluid, how much potassium you will give? 100 milliequivalent, right? Because 5 into 20 equal to 100. Okay, so this will be your answer in this patient. 3 liter normal saline, 2 liter dextrose in aqua, and 100 milliequivalent of potassium. If you go back to your options, you will get that. So that's your D option, 3 liter normal saline, 2 liters dextrose, and 100 milliequivalent potassium chloride. Okay? So just remember, first find out what is the input and what is the output, then find out the deficit amount, and then very easy, you remember this 1 liter normal saline plus 2 liter dextrose plus 20 milliequivalent of potassium per liter of fluid you are giving. And then just add the extra deficit amount in the normal saline and you get the answer. Clear, everyone? Any confusion with this? So normal potassium is between 3.5 to 4.5. This patient have potassium 3. Why did we add extra 2 liter? Because this patient has a deficit of 2 liter. So you have got in, so that's why we have done the math. Input is 2 liter in this case, and output is, we found from the math in here, it's around 3.7 liter. We made it whole, which is 4 liter. So patient getting 2 liter input, but having an output of 4 liter. So how much deficit this patient having? 2 liter. So that extra 2 liter that patient is having deficit, you are adding it to the normal saline in this regular maintenance fluid. And if potassium is normal, then you don't need to give extra potassium. Any question with this one? Any confusion with the math? Because that's where a lot of candidate gets confusion. So the potassium part in here is that, as we can see, that this patient has already got a low potassium. So potassium is 3. Normally it's 3.5 to 4.5. And many times a patient after surgery, they tends to lose potassium. So it's a good idea to give some replacement. But if patient having obviously patient having hyperkalemia, you would not give them potassium again. So it depends on the scenario, obviously. But we're discussing about this particular scenario where patient already having this is a post-operative period and patient's potassium is already low. So based on this scenario, we are giving the patient's potassium. Okay. And yes, like the main thing is that you can give any of those, dextrose in aqua, you can give DNS, you can give Ringer's lactate, doesn't matter. Okay, it can be given. But this is the ideal one that we give in the patients. And this discussion is from T. Jandra, which is what we normally follow for surgical patients. Okay, the next question. Patient comes back from Thailand with history of having sex with multiple prostitutes. After 1 week, patient presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, and sore throat. Atypical lymphocytes present. Monospot test is negative. What is the diagnosis? So this is a very typical scenario. Patient coming back from Thailand with history of having sex with multiple prostitutes. After 1 week, so this incubation time is also important. After 1 week, patient is coming with lymphadenopathy, mild pharyngeal erythema, splenomegaly, and a sore throat. There is atypical lymphocytes present. Monospot test is negative. Monospot test is usually done to diagnose Epstein-Barr virus or infectious mononucleosis. So that has been negative. What is the diagnosis in this patient? So see that I told you that there are some trap in the question. This monospot test negative is a trap. Just because patient's monospot test is negative, it doesn't exclude the likelihood of Epstein-Barr virus infection. Okay, so it's not that always monospot test will be positive in an infectious mononucleosis patient. There are times, many times, like it's not like even 50% cases patient's monospot test can be negative, but still patient has got infectious mononucleosis or EVB. So that's a trap in this question. So many people will just think, well, monospot is negative, so it's not EVB. But the answer here is actually Epstein-Barr virus infection. And why? That's the main question. So the another trap can be that patient had sex with multiple prostitutes. Many will think about HIV just by reading that first line. Always remember that something which is given very clearly, if something is very clearly, it's most of the time that it is a trap set by the examiner. Okay, like if let's say that you never prepared for AMC MCQ, if you see this first line, you will not even read the other lines. You will immediately just tick HIV. So that's a trap. All right. So read the full question and then think that, well, what can be the most likely diagnosis in this patient? So you have found in this patient lymphadenopathy, pharyngeal erythema, splenomegaly, sore throat, atypical lymphocyte. Have a look on this Epstein-Barr virus infection versus HIV infection. So Epstein-Barr virus usually a little bit insidious onset. HIV can be acute, can be chronic onset. Fever is positive in both. Fatigue is common in both. Tonsillar hypertrophy and pharyngitis is more common in Epstein-Barr virus. So if a patient has got tonsillar problem like tonsillar exudate, sore throat, those are more common in Epstein-Barr virus rather than HIV. Whereas oral ulcer is common in HIV. Rash common in HIV. Jaundice, it can be found in Epstein-Barr virus, rarely in HIV. Cervical lymphadenopathy can be found in both. Hepatomegaly, splenomegaly. As you can see, splenomegaly 50% cases you can find in EVB, very rare in HIV. Atypical lymphocyte you can get in both. So there are lots of symptoms and findings which goes with both EVB and HIV. But the main thing in this question is that patient has got sore throat, patient has got tonsillar or pharyngeal erythema. That leads to more Epstein-Barr virus as well as splenomegaly. So these questions, especially sore throat, splenomegaly, pharyngeal erythema, not very common in HIV patient. Okay, that's why we are thinking Epstein-Barr virus. Ross River fever, some of you told about it. It's common in Queensland, especially tropical Queensland areas where there is chance of mosquito bite. And patient will usually present to you with fever, a maculopapular rash all over the body, and they can also have generalized lymphadenopathy and a prolonged fatigue and tiredness. And they can also get joint pain. Okay. And CMV infection, it's not very common to get, and it's mainly common in organ transplant patient, and especially patients who are immunocompromised. All right, moving on to the next. Man coming back after short trip from endemic area for only 5 days with severe jaundice. Patient also having fever. On examination, you found tender hepatomegaly. So tender liver with enlarged 5 cm under costal margin, which means fever, severe jaundice, and tender hepatomegaly. You have done investigations, found very high ALT and AST, GGT and ALP. What is your diagnosis? So patient has a history of traveling to an endemic area. They haven't mentioned which kind of endemic region it is, but patient having jaundice, fever, tender hepatomegaly. The main thing is that investigations finding, you can see patient has got high ALT, AST. So are we thinking about viral hepatitis A, hepatitis B, malaria, infectious mononucleosis, or cholelocholithiasis? Now let's come from the If we are not sure, we always use the exclusion method. See the choledocholithiasis. Choledocholithiasis means bile duct stone. For bile duct stone, patient doesn't present with tender hepatomegaly, very unlikely, and they will mainly have high ALP, not AST-ALT. So it's unlikely. Infectious mononucleosis causing severe jaundice is very unusual. In 5% cases, they can do it. So we would not think about something rare like that. Malaria, acute malaria usually doesn't give you tender hepatomegaly. Chronic malaria can do that. So this patient just came back after 5 days. So unlikely for a acute malaria to do something like that. Now between hepatitis A and B, this endemic, this gives you the diagnosis of hepatitis A, because hepatitis B is not endemic in any way. It's unlikely to be an endemic area for hepatitis B. Common is to have endemic regions for hepatitis A, like if the patient goes to Thailand, if patient goes to some other areas, especially Southeast Asian countries, then there is a likelihood of more hepatitis A. Okay, so we would go for hepatitis A rather than hepatitis B in this case. If there was history of sexual intercourse with multiple prostitutes or IV drug abuse, then we could think about hepatitis B. So we know about hepatitis A. So all of you know about that there is pre-icteric phase, there is icteric phase, and then there is a resolution phase. So in pre-icteric phase, patient usually presents with systemic features like fever, malaise, headache, sometimes anorexia, nausea, vomiting, little bit of abdominal discomfort. And then the icteric phase begins, which starts with jaundice, hepatomegaly, dark urine, and pale stool. Tender hepatomegaly, the cause of tender hepatomegaly is viral hepatitis, congestive cardiac failure, and liver abscess. We also should know about this liver function test finding. So always remember, if ALT and AST is high, that more goes with viral or hepatocellular hepatitis. If alkaline phosphatase is high, that goes more with the obstructive jaundice. Okay. If GGT, which is the gamma glutamyl transferase, is high, that goes with alcoholic liver disease. All right. Let's move on to the next question. We have got a patient. Let's say this is a patient who is 50-year-old, so 50-year-old male, presenting with a parotid gland swelling. CT shows superficial lobe involvement only, no facial nerve palsy. What is your most appropriate next stage? So you have got a 50-year-old who has got parotid gland swelling. CT shows superficial lobe involvement. He did not comment on anything else. So what would you do next? Do you want to do a FNAC, ultrasound, total parotidectomy, or superficial parotidectomy? So I can see you are between FNAC and ultrasound, these two. Most of you are on FNAC, and you are actually right. Very good. Let's discuss this a little bit. That what is the approach of neck lump? So we normally, if you are reading for medicine related topics, then we would mainly go with the RACGP guideline. Now we are doing a 2 weeks free session now. So we are not discussing much about from where to read, what are the guidelines you should go through. Those are the part of our orientation class, which will be for the course student. We will have our first class on the basic guideline of AMC preparation, which means what are the websites that you should go through, what are the books you should go through. That will be the part of your orientation class. So if any of you are new, especially like you just joined our course, just keep an eye for our orientation class in two weeks time, and in that class we will give you a little bit more detailed idea about those. Okay. Now coming back to this approach to neck mass in adults. So In case of approach to neck mass in adults, go through this RHCGP or AJGP guideline. This is the Australian, the most updated guideline you can find. And we always try to read these things as much as possible because questions come from here. So you can see that what are the red flags for any kind of head and neck cancer. So any mass that's been for more than 2 weeks, recent voice change, dysphagia or odynophagia, ipsilateral ear pain, nasal obstruction, epistaxis, unexplained weight loss. So any of these presents, you are more concerned about a cancer. And obviously a smoker, age more than 40, previous history of head and neck cancer, those are also high risk patients. So first of all, if you have got a patient with a neck lump, what would you do? So obviously you would do examinations, taking a good history, but in terms of investigation, you can see here, first line investigation for all adults at risk of malignancy should start with a CT scan of the neck with contrast. So you do a contrast CT neck plus a FNAC. These two investigations provide complementary information about the primary tumor detection, anatomical localization, and nodal staging. So CT is usually the first line investigation. So you do a CT first, and if CT suggests a possibility of cancer, then you would go for a FNAC. Okay. Now, is there any other time where you can do a ultrasound rather than doing a CT scan? Anyone? Okay. So we would go for ultrasound if the patient is pregnant. In pregnant patient, we would not take the risk of radiation. So pregnant patient, if we can find out something by ultrasound, we would do that. If this patient has got allergy to contrast, or patient has got a severe renal failure where we can't give the contrast, in those cases, we can consider doing an ultrasound. The other question which I was looking for is that if this is a patient who is a child, for a children who has neck lump, we start with an ultrasound first. We don't just send them for CT scan. Okay, so these are the main areas where we can do an ultrasound rather than CT scan. Okay. So coming back to the question, what we would do in this case, we would go for a FNAC. Because this patient is a 50-year-old high-risk patient having a lump, we are always concerned. Same, even if it was saying that patient had got a facial nerve involvement, the initial investigations are always a CT plus a FNAC. You would do a FNAC first, even if there was saying that patient had a facial nerve palsy. Scenario of a patient with fall from the bicycle 1 week ago and a helmet fracture. No confusion, no amnesia, but patient has got headache which increases with coughing. Anyone can say that what does it mean? Headache increasing with coughing. What is the most likely diagnosis? Intracranial hemorrhage or intercerebral hemorrhage, subarachnoid hemorrhage, epidural, subdural, or concussion. So what is this headache increasing with coughing? Raised ICP. Very good, Dr. Jehra. So that means this patient has got raised intracranial pressure. Raised intracranial pressure can be like the patient can have bleeding inside the brain that's causing it, can be bleeding outside the brain causing pressure. Any of those can cause it. So The main part in here is that a patient who has got fall from bicycle 1 week ago had a helmet fracture. No confusion, no amnesia, but now having headache, which increases with coughing. What is the most likely diagnosis? Now the questions are intracranial hemorrhage, subarachnoid hemorrhage. So intracranial hemorrhage, if it is an intracerebral hemorrhage, can it wait for a week for the patient to come to you? No. If that patient having intracranial hemorrhage for 1 week, that patient would be dead. Okay? So it's unlikely to be intracranial or intracerebral hemorrhage just by operation, because they usually come to you within 24 hours. What about subarachnoid hemorrhage? Subarachnoid hemorrhage, it doesn't give you the headache which increases with coughing. The pattern of headache for subarachnoid hemorrhage is a sudden severe thunderclap headache, which starts in the occiput and then it radiates to the whole head. And again, subarachnoid hemorrhage would not wait for a week. It will come to you within 24 hours. Concussion, having no amnesia, it's usually unlikely to be concussion. And concussion headache also doesn't increase with coughing. There must be something which is pushing the brain. Okay? So it cannot be just concussion. So it's between epidural or subdural. Now you think that we'll come back to this. Let's discuss a little bit. So epidural hematoma and subdural hematoma. So you all know about the epidural space, subdural space, right? So you can, for epidural, that means the space above the dura mater, that's epidural. So what is the cause of epidural hematoma? Skull fracture from blunt trauma causes laceration of the arterial vessels, most commonly the middle meningeal artery. Fracture most commonly occur in the region of temporal bone. In contrast to the subdural hematoma, a tremendous force is usually required. So usually a very heavy force is required to do this epidural hematoma. So the classic presentation for epidural hematoma is patient usually comes with triphagic presentation. So initially brief loss of consciousness followed by a lucid interval. In lucid interval, patient is completely fine. Patient looks completely normal, and then patient gets the headache again, progressive obtundation and hemiparesis. So that's triphagic presentation. Now, is it always a epidural hematoma patient presents with this? No. It's a classic presentation, but there is a lot of other way of presentation for a epidural hematoma patient. You would not get this lucid interval in a lot of patients who is suffering from epidural. Coming to the, so if you do a CT scan in an epidural hematoma patient, it looks like this. See this biconvex, this is what you get. So in a CT scan, the brain structures will look grayish or blackish, like this. This is how it looks like. And any blood or any fluid will look white. And also the bone will look whitish. So this is the blood, obviously. Now, if you get a biconvex shaped like this, so if you get a biconvex shaped shadow, that's epidural hematoma. Okay. And the subdural hematoma usually looks like a semi-lunar like this. Okay. So that's what you get in a patient with subdural hematoma. Now, if you look at subdural hematoma happens because of rupture of the bridging veins. These bridging veins are susceptible to rupture because the brain floats freely in CSF, and sometimes during trauma, when brain suddenly struck the skull, this bridging vein can rupture. So displacement of the brain can cause tearing of these bridging veins, causing the subdural hematoma. Sometimes subdural hematoma can even happen with minor trauma or even spontaneously. So it doesn't need to have a tremendous force to have a subdural hematoma. Now, subdural hematoma patient can present with a lot of findings such as headache, altered mental status. Patient can have hemiparesis. So, what I'm trying to say is that what do you think this patient has got, epidural or subdural, and why you think that? Very good, Dr. Atika and Dr. Shuasha. It's epidural. Why? Because see, this patient had a helmet fracture. Having a helmet fracture needs a tremendous force. Okay? So subdural hematoma can even happen with a minor injury. Even you don't need any injury to get a subdural hematoma sometimes. So it's unlikely to have a subdural hematoma where patient had got this helmet fracture. So when a patient had got a tremendous injury causing helmet fracture, it's most likely it goes with epidural hematoma rather than subdural. Okay, clear everyone? Now, yes, epidural hematoma can present after a week. It's still not chronic. Chronic presentation is like maybe after a month. Subdural hematoma patient can present to you after 6 months. So there is a lot of time, 50-year-old patient coming to you with a sudden onset of confusion, forgetfulness for the last 1 month. When you ask the patient recounts that he had a minor fall 1 month ago. What is the next step in this patient? The next step in that patient is to rule out subdural hematoma because that patient most likely suffering from chronic subdural hematoma from that fall. So you would do a CT or MRI brain of that patient. So subdural hematoma takes a very long time sometimes to present, but 1 week is still, it is within the injury time. Epidural can present even with a week. It's fine. Okay. So the main part is that this helmet fracture, it's patient usually needs a very heavy trauma to get a helmet fracture. It's not easy to break a helmet, trust me. So when it happens like that, it's better to go with the epidural rather than subdural because subdural can happen even with a minor trauma. It doesn't need a helmet fracture for it. No, if you suspect hemorrhage or hematoma, then you don't do contrast. You do a plain non-contrast CT. Good. Moving on to the next. Parents came to you that their son has hereditary spherocytosis. They want to know what is the chance that his siblings will also get the same disease. So this is a genetic question. Genetic questions are also important for your exam, but it's not like you need to know a whole lot of genetics for AMC MCQ. You just need to get a basic idea about autosomal dominant inheritance and autosomal recessive and X-linked recessive. So today I'm giving you some basic ideas about how the autosomal dominant and autosomal recessive patients work. Okay, and then we will come back to this question. So the question is about hereditary spherocytosis. So you need to know what kind of genetic condition it is. Is it autosomal dominant, recessive, or X-linked? So what do you think? It's autosomal dominant, not recessive. Okay, so it's an autosomal dominant case most of the time. So let's come back to hereditary spherocytosis. So autosomal dominant inheritance, how this works. So you need to know these basic ideas just to answer the tricky questions in the exam, because a lot of times there are lots of tricky genetic questions we see that you guys get. So you need to have that idea to answer those complex questions. So for the sake of understanding, we will keep this male as X and Y, female as X and X. Now, this XY can be AA, BB. So remember, this is not the X-linked chromosomal distribution that we are discussing. So don't get confused about the X-linked in here. So even if you want, you can keep it as AA and BB. That's fine. Now, in case of autosomal dominant, if only one defective gene comes from your parents, then you can get the disease. Whereas in case of autosomal recessive inheritance, you need two defective genes from your parents to become an active diseased patient. How this works? So let's say that in this patient, so this is the male and this is female. So this is father and mother. So in father, let's say this Y chromosome, this has a defective gene for hereditary spherocytosis. Okay. So what is the chances that their son and daughter can get the disease? That's the question. So there are four possibilities when there is a possibility of a baby. So XX, XX, then this Y prime X, and same XY prime. Now, in here, you can see that this child doesn't have any defective gene, so it's normal. This child doesn't have any defective gene, this is normal. This child has got a defective gene. And as I said, in autosomal dominant, you only need one defective gene to become fully diseased. So this is a diseased child. Same with this child, this is also a diseased child. So what you see in here, 50% of the child will be normal, 50% of the child can have the disease. So this is always the risk of having a diseased child. So the question asking that, you can see here, parents came to you because their son has hereditary spherocytosis. They want to know what is the chance that his siblings will get the same disease. Which means that this parents, one of the parent also has got hereditary spherocytosis. Okay. Now, the question is, what is the chance that the siblings will get it? So 25% of the brother, 50% of sister, 50% of brother, 0% of brother and sister, 50% of brother and sister. Always remember, in autosomal dominant, the disease can happen in either daughter or son. It doesn't matter. It can affect anyone. So we already know from this discussion that 50% of son and daughter, or 50% of his brothers and sister, can get the disease. And this is not for, like, if you think that this parent has got already one son with hereditary spherocytosis, okay, why not there is only 25% is remaining? It's not like that. Don't think in that way. Think that in each pregnancy, there is a chance that 50% of their son and daughter might have the disease and 50% might not have the disease. So that is the risk that they have to take in every pregnancy. Okay, so that's your answer in here. 50% of his brothers and sister can get the disease. Now that we know about the X-linked, we know about the autosomal dominant, let's talk about autosomal recessive a little bit. Is this making sense, guys? Yeah, very good. Okay, now let's say that this is XY and this is XX. So in autosomal recessive, there is possibility of multiple findings. Let's say we have got the father has got one defective gene, so he is a carrier of thalassemia. So father has got thalassemia minor, and mother also has got thalassemia minor. So one defective gene in each parent. So what is the possibilities? So first this X and X, so X prime, and then we have got X and X prime. Then we think about X prime Y, and this Y and X, so XY. So these are the four possibilities. So we can see that this is normal. This has one defective gene. So that's a carrier, not a full disease. This one also one defective gene, so that's a carrier. So these two are thalassemia minor. And this one has got two defective genes. So that's a diseased child or thalassemia major child. So the question comes that if both parents are thalassemia minor, what is the risk of their son and daughter to get the thalassemia major or to get the active disease of thalassemia? So the chance is, you can see in here that 25% is normal, 25% chance of having the thalassemia major, and 50% thalassemia minor. So that is the risk that you can have. So you have to know this to answer this right, because a lot of way they can make these kind of questions. Okay? Clear, everyone? Now, obviously, if just only one parent is diseased or having the defective gene, then the scenario will be different. If only one parent has got thalassemia major and other parent is totally normal, the scenario will become different. So now you know what to do, right? So you will just find out from this kind of, so let's say if father is major, and you can see that in here, the mother is normal. So what will happen? So you can see X prime, X prime, XY prime, XY prime. So you can see that everyone can be carrier. Okay, so it depends always that how the scenarios are coming in the exam. Based on that, now you know how to find this. So they can give you any kind of scenario in the exam, but the basic idea is important. As long as you understand this basic, whatever questions they are giving, you will know what is the answer. Okay. So we are going back to this question answer. So this will be 50% of brother and sister who has got the disease. No, that is X-linked, where females are usually the carrier and not affected, and males will be affected. That's the X-linked recessive condition where this happens, not in the autosomal dominant or recessive condition. We are not discussing the X-linked today. It will be discussed in the class. Okay, moving on. A nurse suffered a needle-stick injury at your ward. Okay, she had previous hepatitis B vaccine 10 years ago with a positive serology. So patient had previous hepatitis B vaccine. Now this is a very tricky, complicated question. So try to understand it. So this is a needle-stick injury or occupational needle-stick injury. We know that in a needle-stick injury, there is a victim and then there is a source. So source and the victim, these two is important to know. So in here, who is the victim? Nurse. So victim or the nurse has got hepatitis B vaccine 10 years ago with a positive serology, which means she had antibody, but for 10 years she hadn't taken any booster. So after 10 years, this hepatitis B vaccine, the immunity sometimes can go low. So you never know. Patients, the source is the patient, right? So patient's HIV is negative, but hepatitis B, so HBsAg, so surface antigen is positive, and hepatitis C virus PCR RNA is positive. Now that becomes a tricky point, right? So we can see that the source has got positive hepatitis B and hepatitis C. Now in this case, the victim is risky. So the victim has the risk to get both hepatitis B and C. Okay, so what you want to do next? You want to just give prophylactic antiretroviral and tenofovir. Now you can exclude that because we know that patient or source HIV is negative, so you don't need to give this antiretroviral for HIV. Same for tenofovir, that's also for HIV, we don't need to give it. C, repeat the nurse hepatitis C virus RNA after 3 weeks. Check the nurse hepatitis B antibody level. So what do you want to do next? The answer which is correct is to check the nurse's hepatitis B antibody level. Why? Because just I said that this patient, the nurse, had hepatitis B vaccine 10 years ago, but she hadn't taken any booster after that. And we don't know how much immunity she has left. Because even if the patient has got hepatitis B vaccine, after 10 years, she might not have any antibody left in her body. So the only way we can be sure if she has got antibody is to check the antibody level. Ideally, if the patient has got anti-HBs more than 10, she is immune. And that's what we want to check, because if she is immune, then we are not worried about getting hepatitis B, because she will not get hepatitis B if she is already immune to it. So the risk will be to get a hepatitis C in that case. And you can't do anything about it because you can't give a vaccine or immunoglobulin right now, which can help her. Okay, so the best approach in here is to go for a hepatitis B antibody level to check her immunity. Now, this is a very, very broad discussion, very complicated, complex discussion, which I would not be bothered in a question solved class, but I will show you the guideline from where we are discussing this. This is the Queensland guideline, which is a very good comprehensive guideline for any kind of occupational injury. So let's open this one. So in case of any kind of needle stick injury or occupational injury, you will come to that guideline, and this guideline has every possible scenarios answer. So let's find out hepatitis B virus post-exposure prophylaxis. So let's have a look at what we normally do in these cases. First of all, we need to know what is the source status. If the source is known to be hepatitis B positive, or if the source is negative for hepatitis B. So that's one thing we need to know. And we need to know about the victim. Does the victim's current hepatitis B antibody more than 10? Or if the current hepatitis B antibody level less than 10? If the patient is a non-responder. Non-responders are patients who had hepatitis B vaccine, but they don't get the immunity. Okay? Now, that's why we need to know the hepatitis B antibody level. So if the patient having an antibody more than 10, then there is no treatment needed in any way. But if the antibody level is less than 10, and patient is a known vaccine responder. So there is also one other thing, that if a patient is known responder, that means patient responded to vaccine before, but currently her immunity is less than 10. In that case, still we can take a risk. We can just start the patient, we can just give the vaccine to the patient, okay? Or we can even take the risk because patient is a known responder. So even in that case, you don't need to give any treatment. The only treatment we give is that if a patient is a non-responder, which means that patient previously had hepatitis B vaccine, but she was not getting the immunity level, which is that even with the primary course of hepatitis B vaccine, she did not get the immunity. In that case, if the source is hepatitis B positive, you have to give immunoglobulin as well as vaccine, both. Okay? If the source is negative for hepatitis B, then just vaccine. All right? So this is what you need to remember from this. And that comes in exam. And there is a lot of other discussion which I would not go now. We would discuss in our class anyway. Let's see if there is any chart that I can show you. Yeah. So this is the main summary of everything that we are discussing, or everything that is written in this guideline. So let's say you have got a patient who has got exposure to blood or fluid. That means a needle stick injury. First thing is assess the risk. If the source is unknown, then you have to just consult the infectious disease specialist. If the source is known, that means you know the source, or the source is likely to be HIV or hepatitis C virus positive. If this is the case, then notify the infectious disease specialist, because you need to start the patient with some prophylactic antivirals. If it is no, so is the source known? No. Likely to be HIV or hep C positive? No. In that case, the first thing we would do is to take a baseline blood from the victim. So baseline blood will check for our HIV antibody level, hepatitis B antibody level, and hepatitis C virus antibody level. So we will do a baseline antibody check from the victim in that case. And that usually will be done for every kind of patients in a normal scenario. Now, the next thing we check for, does the victim has got hepatitis B antibody more than 10? If she has got hepatitis B antibody more than 10, then there is no indication of hepatitis B vaccine. No indication of immunoglobulin either. Okay? But if there is lack of immunity, that means hepatitis B antibody is not more than 10, then there are some scenario. So you will start the patient with hepatitis B vaccine, and only time you will give the immunoglobulin if the source is known to be hepatitis B virus positive. Okay? And then you will do follow-up testing. So usually every 4 to 6 weeks, you will check the hepatitis C virus and HIV antibody level in this patient. Okay? So that's the step-by-step approach. I know that this is still not clear 100%. What I would like you to do is to go into this guideline and read it a little bit, or even just print it out. Because all you need to do is to read it clearly to get the best idea from this. But what I want you to understand, that any kind of occupational injury, we first try to find out if the source is known or unknown. If the source is known, then it is easy for us to manage the patient or manage the victim, because we can then find out if the source is a risky source or not. Okay? If we already know that the source is known, but source doesn't have any problem or doesn't have any virus positive, that means that's a low risk thing. In that case, what you would do, you would just check the patient's hepatitis B antibody level, and then you do the baseline antibody for HIV and hepatitis C virus. If the source is known for something, then you are more concerned, and obviously you will check the hepatitis B antibody level. If the patient's antibody level is more than 10, you are not worried about hepatitis B anymore. You will just follow up the patient or follow up the victim with repeated tests for hepatitis C virus and HIV. And if we know that the source is already positive for hepatitis B virus and patient is not immune to hepatitis B, in that case, you have to go for immunoglobulin plus vaccine. Okay? Clear, everyone? Does it make any sense? I know it's a little tricky to get. But for this question, it is easy to understand that all we need to do is to check the hepatitis B antibody level, because then we can find out if we need to give any antivirals or anything to these patients or not. Okay. Excuse me, guys. Yes. So Dr. Rabia, the question you asked, that's what they have done, right? So she had her vaccine 10 years ago with a positive serology. Positive serology means she had antibody at that time. But hepatitis B is something like that the immunity can gradually come down. So even if she had the immunity back then, she might not have the immunity right now. So yes, even in that case, you would check her antibody level right now. So current antibody level is important. Okay, moving on to the next. A lady comes to you with weakness of lower limbs. She drags her foot while walking. Dorsiflexion and plantar flexion is weak. Reflex are exaggerated, but there is equivocal plantar response. What is the diagnosis? So you have got a lady coming to you with weakness of lower limbs. She is dragging her foot while walking. That sounds logical, right? Because she has weakness of lower limbs, so she will drag her foot anyway. Dorsiflexion and plantar flexion is weak. Her reflex are exaggerated. So reflex increased, but plantar response is equivocal. So plantar is fine. So what was your diagnosis in this patient? So do you think it's a cervical spine MS, motor neuron disease, spinal canal stenosis, lesion in cerebral cortex? They're asking about the diagnosis. Okay. Okay, most of you are going with B, motor neuron disease. So very good. So this is actually motor neuron disease. Why and how? Now, motor neuron disease is a condition which affects the motor neurons in your brain, spinal cord, everywhere. So wherever you have got motor neuron disease can affect that. The name is motor neuron disease. So it only affects the motor part of your body, not the sensory part, which also you can see here in the question, there is no sensory problem. Okay, that gives a good clue, and you can easily rule out a lot of conditions just by on that part. So if a patient has got cervical spine MS, okay, or let's say even if we think that cervical spine myelopathy or cervical spine MS, whatever it is, in case of cervical spine, they should also have weakness in their arms, not only just the leg, right? So this patient only has got weakness of the lower limbs. So cervical spine obviously doesn't fulfill the criteria. The next is spinal canal stenosis. They haven't mentioned that what and where is the spinal canal stenosis. Let's say it's a lumbar spinal canal stenosis. In case of spinal canal stenosis, it most of the time will give you a upper motor neuron type of signs. And it will also give you both sensory and motor problem. This patient doesn't have any sensory problem, just motor problem. The complexity in here is that this patient has got both upper motor and lower motor neuron type of signs. How? First of all, she has got weakness, because if it is like flaccid paralysis, patient usually drag their foot. So this patient has got weakness of the lower limb, so paraplegia, and patient has got equivocal plantar response. So these two goes with lower motor neuron type of sign, whereas reflex exaggerated goes with upper motor neuron type of sign. So we say that if a patient has got both upper motor neuron and lower motor neuron type of feature in their limbs or in a single limb, that's likely chance that patient has got a motor neuron disease. Okay, so this patient has got both upper motor and lower motor neuron type of feature, which suggests possibility of a motor neuron disease anyway. And why it is not let's say why it is not lumbar spinal canal stenosis. In a lumbar spinal canal stenosis, patient will complain back pain, and the patient usually will have both motor and sensory symptoms, and all the signs will be upper motor neuron type of signs. Okay, so that's also unlikely in this patient. Lesion in the cerebral cortex. Now, lesion in the cerebral cortex is a very vague term. The question is important. I always say, read the question, what they're asking. They're asking the diagnosis. If they would ask that where is the site of the lesion, then we could think of getting the cerebral cortex lesion. But they're asking that what is the diagnosis? In case of diagnosis, it is much better to choose the motor neuron disease rather than lesion in the cerebral cortex. Although motor neuron disease is actually a lesion in the cerebral cortex, but among B and D, B is better option to choose. Okay, so that's why we think it as motor neuron disease. So all of you might already know what is upper motor neuron type of palsy and what is lower motor neuron type of palsy. We will discuss this in our neurology class in the course in detail, so you will understand that in much better way. Now the same question, now you can understand that why and how sometimes we choose different answer, but same question. 58-year-old man, dragging left foot, reflex on the left lower limb are increased. Plantar flexion, dorsiflexion is weak. Weak ankle movement, equivocal plantar reflex, but upper limb and face normal. What is the site of lesion? Common peroneal nerve, cervical spinal cord is unlikely because there is no upper limb symptoms. L5-S1 nerve root, cerebral cortex, brainstem. So what is the diagnosis in here? Same, it is still motor neuron disease, most likely. Okay, now let's find out that how we can rule out these common options. So first of all, common peroneal nerve. Common peroneal nerve is a peripheral nerve. Any peripheral nerve doesn't impact the reflex. So common peroneal nerve is a peripheral nerve, so it should not cause any problem with the reflex, but this patient has got a reflex increased. Right? Now, common peroneal nerve is unlikely even based on that. How about L5-S1 nerve root? L5-S1 nerve root, the presentation is a sciatic presentation, which means patient will come to you with a low back pain, which is a shooting from the back of the thigh going down to the foot. Okay, that's a sciatic pain, but again, L5-S1, this doesn't give you any problem with the plantar reflex, and most importantly, L5-S1 nerve root doesn't cause the reflex problem because L5 doesn't give any reflex anyway. Okay, so S1 can give you ankle reflex, but L5 doesn't give any reflex. But they're saying that reflex on the left lower limb are increased. So L5, it doesn't cause any problem with the knee reflex. So knee reflex root value is L3, L4, and ankle jerk S1, S2. So L5 doesn't have any reflex problem. So when reflex is increased, we can't think of L5 nerve root problem. And again, the symptom doesn't go with it. We know that it can cause this problem with the dorsiflexion because if patient has loss of dorsiflexion, then they will drag their foot. But always remember, L5S1 doesn't cause any problem with the plantar flexion. Plantar flexion is more with the other nerves. Dorsiflexion is caused by L5. Okay. But the main thing that we are looking for that L5S1 nerve root should not cause all the lower limb reflex to go up. Okay. How about brainstem? In brainstem injury, patient would not only have this motor problem, they would have most of the time they would have diplopia, nystagmus. They can also have problem with swallowing. So they can have dysphagia. So there will be more problem with the bulbar and pseudobulbar problems, which this patient doesn't have anyway. Okay. So this lesion site is cerebral cortex because you have got a patient in here who is having motor neuron disease. And motor neuron disease, as we said, the patient usually will have all the motor neuron in their cerebral cortex and spinal cord that will be damaged. Okay. So if it is motor neuron disease, the lesion site, most likely it's cerebral cortex. Okay. It's a very tricky thing, and I know that it will be very difficult for you to understand because we haven't discussed this common peroneal nerve. We haven't discussed this nerve root function, which will be discussed in the class anyway. Then these questions become much easier for you to get. Okay, but ideally remember one thing, that any peripheral nerve, which is common peroneal nerve, they usually will not cause any reflex problem. If they're talking about L5S1, I will come to L5S1 just in few questions, but remember L5 cannot cause any reflex problem, but this patient has got reflex issue. Okay, so these two is the main thing that you would want to rule out. Other than that, we know if this is cervical spinal cord problem, patient would have upper limb weakness, which this patient doesn't have. Okay. And also one other thing you might be thinking, that if a patient has got cerebral cortex lesion, how come only the left lower limb is involved? Well, how come the all other parts of the motor neuron is not involved? This is called homunculus, in which you can see that every part of your cerebral cortex, it maintains some kind of function. So this part, it helps with the motor function of the face, this part your hand, this part your leg. So if only this part of the cerebral cortex is involved or got damaged, then patient will have only this leg problem. Okay. So that's how it usually, that explains your confusion also, that how come it is only left foot, not any others. All right, any question with this one, guys? Okay, let's take a 5-minute break now, and then we will restart again. All right, everyone, let's start again. Okay. So you have got two tiny magnet aspirated in a 5-year-old. So two tiny magnet aspirated in a 5-year-old came to the emergency department. After 4 hours, immediate X-ray is done. Magnet is still in the small intestine after 6 hours. Okay. So it should be like this. So patient is a 5-year-old, had a two tiny magnet aspirated, came to the ED after 4 hours. You have done an immediate X-ray. Magnet is in the small intestine at that time. And after 6 hours, you have done a repeat X-ray and showing that magnet is still in the same position. What will you do next? Immediate laxatives, immediate surgery, do nothing, serial X-ray, or immediate endoscopic removal. So two tiny magnet not moving for, let's say, 10 hours, and it's in the small intestine. Let's move on to the discussion. So what are the high risk foreign bodies? Any button batteries are always high risk. Any large object which is more than 6 centimeter long and more than 2.5 centimeter wide. Magnet plus metal, more than one magnet, that's high risk. Our patient had two magnets, so it's a high risk. Lead-based object, and patient had abnormal GI tract already, like a previous GIT surgery or TOF. Now, this is a very important one. Patient had an initial presentation with a witnessed magnet ingestion. First, we think that is it symptomatic or asymptomatic? If it is symptomatic, patient is complaining abdominal pain, then you need to do removal immediately. So either removal can be done by endoscopy or surgery. Okay. So removal can be done either by endoscope or surgery. If it is asymptomatic, like our patient, is it single or multiple? In case of single piece, you can do observation as outpatient, serial X-ray daily, confirm passage by X-ray. If you do serial X-ray and you see that there is no more that foreign body is there, then you can confirm that it has already passed away. In that case, you can discharge the child. No progression on X-ray for 24 hours. Consider that there might be more than one piece. Make sure you do a lateral X-ray, and if there is no progression on X-ray, even if it is a single piece for 24 hours, then removal is indicated. Now, how about multiple piece? If it is multiple piece, you will obviously admit for observation, and you will do a serial X-ray every 4 to 6 hours. Okay, just like how we have done. No progression on X-ray for 4 to 6 hours. So that's what happened in this child. There is no progression for 6 hours. Then removal is indicated. So according to the location, either by endoscopy or by surgery. Okay, so now you know about that you have to remove this either by endoscopy or surgery, right? So, and you have got a patient who has got magnet. So it is a magnet, not battery, but we are discussing about the magnet, Dr. Iman. Okay. So if it is a magnet asymptomatic, multiple piece, you do the admit for observation and you do serial X-ray every 4 to 6 hours, no progression for 4 to 6 hours, you need to remove. This patient, if we see, first of all, it's a two magnet, and you can see that after 6 hours, it is still in the same position, which means it fulfills the criteria for removal. The question is how we remove it. Is it by surgery or endoscopy? Now come to your next one. So we see that there is multiple magnet digestion or suspected, and you have already done history, chest and abdomen X-ray. within or suspected within esophagus and stomach. So if the foreign body is within esophagus or stomach, then you can remove it by endoscopy. You can at least give it a try. So endoscopic removal, if it is successful, then it's good. If it is unsuccessful, then you need to go for surgery. Okay. If you do successful removal, but you perforated this organ during that time, again surgery. The next is beyond the stomach. So if the foreign body is beyond the stomach, what we can do, remove any magnetic and metallic objects nearby, follow with serial X-ray. If patient becomes symptomatic, surgery is indicated. Asymptomatic, if the foreign body is moving, then most likely it will pass away. But if it is lost in the truck, which means if it doesn't move, like our patient, we can see for the 6 hours it's not moving. It is lost in the truck. If that is the case, we have to do surgery because it is very hard to do endoscopic removal of a foreign body from the small intestine. So endoscopy usually will be really hard to go into the small intestine. Same colonoscopy, it will be difficult to go into the small intestine. So the best approach in these cases, it will be surgery. Now you tell me that what do you think this child will need? You have found a 5-year-old and you can see magnet is in the small intestine. So you want to do surgery, do nothing, serial X-ray, immediate endoscopic removal. So this child will need an immediate surgery. Okay. So you can understand that how complicated it can be if you don't know these topics. And it is very hard. And this is how usually we take the classes in that way so that you can actually understand why we are choosing these answers. It's not just we are talking and we are saying our mindful answer. There should be some reference behind the answer. And then only you can be sure about it. Okay. And when you read a certain topic, you should read in that way that anything coming from that topic, you should know about it. Okay. Next, we're now discussing a very interesting question which comes in exam. In exam, there are questions which carries very high mark. There are questions which is simple question, carries maybe two mark. So I think I talked about this in the first trial class, that there are questions which might be just 2 mark. There are questions which might carry 10 mark. So there are some known questions which many times it came in the exam before, it's coming in the exam, and you must know it. So one of that question is this cardiovascular risk assessment chart. Okay. All right. Before we do that, Dr. Tharindu asked, would you please explain why not endoscopic for this patient? Because as you can see that the foreign body is not within the esophagus or stomach, it is in the intestine. In case of intestine or beyond the stomach, you can't remove it by endoscopy. In those situations, we follow this guideline. If the foreign body keep moving, then we just allow it to do that, and we do serial X-ray. If the foreign body becomes static, it's not moving, then for a small intestine, surgery is indicated. But the same magnet, if it was in the stomach, we can do endoscopic removal. Okay, 64-year-old smoker women. So we are now doing a 5-yearly cardiovascular risk assessment chart. So the chart looks like this. So they will give you this chart in the exam. Then they will give you the stem like this. So it's a 64-year-old smoker women, blood pressure 135/68, cholesterol HDL ratio 6.6/1, and they're asking what is her 5-yearly CVD risk. So in the CVD risk chart, you will get like a lot of different kind of population. And this one is patient without diabetes. First of all, you can see on the right-hand side, this is for men, this is for women. Our patient is a woman, so we will mainly look on this side. And we know that our patient is a smoker. So our patient, we are just looking on this part, right? Not anywhere else. So this box, the whole one is our main box. Then the age, we know that patient age is 64. So 64 is this group. So that means our patient is mainly this one. So first you mainly find out which box you are looking at, and then you can see in this chart, this is just like a graph. So in the graph, you have x-axis and y-axis. In the y-axis, you can see you have got systolic blood pressure. And the systolic blood pressure are 120, 140, 160, 179. And then on x-axis, you can see there is cholesterol and HDL ratio. So first thing first, you can see that this is a box. You need to know that this box, what is the highest limit of systolic blood pressure in this box? What do you think? Is it 120? Is it 140, 130? What is the highest limit of this box? That means, yes, the highest limit for this box is up to 130. Or you can say less than 130. So you might get confused at why it is written 120 then. It is written just like that, but always remember, up to 130, any value will be in this box. Same is this one. This is written 140, but highest value in this box is up to 150. Same with this one, 170, like this. Okay. Now, there is another problem that if it is marginal, and AMC is very good with marginal approach. Let's say if someone is 130, where would you put him? If it is marginal, you will go to the next box. Okay. So any marginal, we go to the next. Okay. Same in here. If it is 150, we would choose the next box. Is this making sense? Because you need to know that. Otherwise, you can't put the number in this graph. Okay, some might still have confusion to this. So you need to know that, so this box, you can see that obviously you will be given a systolic blood pressure. Like our patient has got a systolic blood pressure of 135. So you need to know how much you can put in this box, how much you can put in this box, right? So we are saying that this box, the highest number you can put is up to 130. Highest number you can put here is up to 150. This one 170. So don't get confused by these numbers 120. It's not that this box has highest limit of 120. So if the patient's systolic blood pressure is 135, where you are going to put it? This green box or this blue box? Blue box, right? Because up to 130 is this box, and after that, so 135 will be in here. Okay. This graph will be provided to you. You don't need to know this graph. Obviously, you can't memorize this graph. So that's the first thing. The next part is your x-axis. So you have got cholesterol HDL ratio. You can see that the ratio is given as 4, 5, 6, 7, 8. Okay. So 4, 5, 6, 7, 8. No. So again, you guys are making it confusing. So the first box, it is up to 130, not up to 139. Okay, this is according to the Australian Heart Foundation guideline. We will show it to you in case you are confused. So this one, this first box is up to 130. The second box is up to 150. It's very easy if you know that if it is 120 written, just add 10. That's the highest limit. If 140 written in here, up to 150 is your highest limit. Just add 10 to it and it is easier in that way. Okay? It's very simple if you don't make it confused. Now, the same thing will apply in the cholesterol HDL ratio. Okay. Again, Dr. Mohit, so what do you think where the 131 to 139 will be there? So why it is confusing you? You can see here that up to 130 is this box. So obviously 131 and up to 131 to 150 will be this blue box, right? Very simple. Okay, good. The next one is cholesterol and HDL ratio. If you see here, the cholesterol HDL ratio, they have written in here as 4, 5, 6, 7, 8. But there is a but here again. So this one, this box, the highest number you can put in is up to 4.5. Okay. Same in here, up to 5.5. This box 6.5. This box 7.5, 8.5. Okay. Clear? Very good. Now let's come to the point. We already have done the systolic blood pressure 135 in this patient. Now we have got 6.6 is the cholesterol ratio. So 6.6, we need to know where the 6.6 will be falling. So we know that this one, this box has up to 6.5. So from 6.6 will be in this box. Now we will just move up, right? We move up this area. So this one, right? Because our blood pressure fall in this box in here and our cholesterol value fall here. So this yellow one or yellow box is the patient's CVD risk. Okay, is this understandable? It is just like how we do the statistics, and you just need to find out the X and Y point and then find out which color the patient is in. Now, every color has some risk in here. We will show you the CVD risk now. So this is the Australian cardiovascular risk chart that we have shown you. So you can see that every chart and every box has some percentage, and that's the question asked you. And what is the risk in this patient? So our patient had this one, right? So the yellow one. So the patient will have a 16 to 19% risk, and this will be given in your exam. So you don't need to memorize anything. So you just need to find out the correct color. That's all that you need to do. Now, some of you had a confusion about this, and I will just show it to you. You can see that they have written in here, for example, the lower left cell. So lower left cell contains all non-smoker without diabetes. So lower left. So without diabetes, non-smoker, so this side. And let's talk, they're talking about this one, let's say. So lower left cell who are 35 to 44, so this one, and have a total cholesterol HDL ratio less than 4.5. So they're talking about this lower left cell. the lower left cell has up to 4.5 total cholesterol HDL ratio and systolic blood pressure of less than 130. So systolic blood pressure is less than 130. So that's what we have discussed, that this box, the highest limit you can go is up to 4.5 and this is up to 130. But in case it becomes marginal, like if it is 130 systolic blood pressure, you will go to the next box. If the cholesterol ratio is 4.5, you will go to the next box. Okay? Clear, everyone? And obviously, ethnicity and Aboriginal Torres Strait Islander, they have different than the other populations. Aboriginal Torres Strait, they are always high risk. And for them, you use this part. As you can see, it's written, charts in this age bracket are for use in the Aboriginal and Torres Strait Islander population only. Because normally we don't do the CVD risk assessment in less than 45-year-old. But Aboriginal Torres Strait Islander, we start from 35. Let's talk about you. So 6.6 lies in 7 box. So 6.6. So we know that up to 4.5 here, 5.5 here, 6.5 here. So 6.6 will be in the 7 box. Good. How about 4.4? 4.4 will be in here because up to 4.5 you can keep it here. Yeah, and that's the also important thing, Dr. Atika. Highest limit of systolic blood pressure and cholesterol. If it is marginal, you move to the next box. Okay. I think now you have got it, right? It is confusing, I understand, but if you understand it once, you will never forget. But a lot of people has very controversial thinking about this chart, and they give you wrong guideline. But now you have seen the guideline, so you should not be confused anymore. And also nowadays we have changed this Australian cardiovascular risk chart anyway. So there is a new guideline which is now more commonly we just started to use. So if you write the Australian CVD risk calculator, then you will find out the new guideline. In that guideline, there's a lot of other things that we are including for the risk assessment. But at the moment, still now, this chart is important. And like in AMC MCQ, they can't actually give you that new one because new one has a lot of like it's a very complicated ones. But at least if you know how to put the risk assessment like this one, you should be fine for the exam. Okay? And do we have to memorize this chart? No, no need to memorize this chart. Okay, let's move on to the next. So this is a question from handbook, but it's also important for you to understand the nerve problem. So the nerve problem comes in exam a lot, and these are the questions which carries high mark in your exam. The one that we have just done, CVD risk chart, very important. Likely chance it carries high mark. Any question which has ECG in it, most likely it carries high mark. Questions that's like this kind of nerve problem, neurological problem, those are high mark because those are a little bit complex question and it carries high mark. Okay, so let's talk about the upper limb neuropathy. So today we are mainly focusing on a particular nerve, not the whole nerves. and you will understand which one we are discussing. So you have got a patient who has sustained a stab wound to the back of the left forearm in a pub brawl. So this is the left hand forearm. Most likely patient has got a stab wound here. He is trying to straighten his fingers on command. So you can see that patient is able to straighten the fingers on the right hand, but patient is unable to do the finger extension, right? So finger extension on the left hand is impaired, but we can see the wrist is fine. So patient can do the wrist straightening, but patient can't do the finger straightening. Which one of the following nerve is most likely to have been injured here? So is it median nerve, ulnar nerve, radial nerve, posterior interosseous nerve, or anterior interosseous nerve? Okay, we will discuss this very quickly, and this will be our last question. So for a radial nerve injury, we need to know the radial nerve anatomy first. So if you see this one, so a radial nerve, you can see that it's starting from the brachial plexus, and then around the spiral groove of humerus, it's getting like this, and then it comes from the back of your humerus, and then it comes forward at the elbow, and then it divides into its two branches. One of these branches is called posterior interosseous nerve, and another is called superficial radial nerve. Okay, so these are the two branches of radial nerve. Now you will need to know that what kind of finding you will get if a patient has got radial nerve injury at the elbow, at the axilla, or at the wrist. So first of all, injury of radial nerve at axilla. And even before that, you need to know what are the main motor and sensory function of this. So radial nerve, the main motor function is it helps with extension of the forearm. So your forearm extension. So let's just draw a picture like this. So your forearm extension. So every extension will be done by radial nerve. So forearm extension, and then wrist extension, and finger extension. All extension will be done by radial nerve. It also helps with supination of the forearm. Okay. And how about the sensory function? If you see here, this is the palmar aspect of your hand, and this is the dorsal aspect of your hand. On the palmar aspect, the 3.5 finger. So this 3.5 finger is supplied by median nerve, and this 1.5 finger is supplied by ulnar nerve. And if we are looking at the dorsal aspect of the hand, the 3.5 finger is given by radial nerve. So this one, the same median nerve on the palmar aspect. When you ask the patient to turn over, the dorsum of the hand will be supplied by radial nerve. So this is a wrong picture, so it should be up to this. Okay. So this 1.5 finger or on the dorsal aspect is supplied by ulnar nerve. So ulnar nerve is same on both sides, but on the palmar side it is median nerve. On the dorsal side it is radial nerve. Okay. So this is the sensory function. Now that you know the motor and sensory function, let's come back. So if a patient has got injury at the axilla, so there is an injury over here. So what will be the function? So everything will be lost, right? So that means patient will have loss of extension of the forearm, loss of extension of the finger and wrist, and also weakness of the supination. And also they will have a sensory deficit over the forearm and also that dorsal 3.5 finger. That means everything is lost. Okay. Now, what if it is just below the elbow? This one is important. So sometimes patient can have supracondylar fracture. So just a fracture over here. If a patient has got a injury of the radial nerve at the elbow, what will be your findings? So motor deficit, in that case, patient usually will injure their posterior interosseous nerve. So we say that if a patient has got injury to the elbow, most of the time this posterior interosseous nerve is the injured one. So if posterior interosseous nerve is injured, posterior interosseous nerve is a motor nerve. It doesn't have any sensory function. So only problem will be motor deficit. And what will be the main problem? There will be no problem in the forearm, but the main issue will be extension of the fingers. Okay, so the posterior interosseous nerve, the only thing it does is it helps with extension of the fingers. So that extension of finger will be lost. And all other things like extension of the wrist, extension of the forearm, everything will be fine. Okay, and there will be no sensory loss. How about there is injury at the distal forearm closer to the wrist? If a patient has got distal forearm injury, it mainly affects the superficial branch of the radial nerve, and that is entirely sensory. Okay, so that means patient will only have loss of sensory function in that 3.5 finger. Okay, now if we look over here, you can easily find out if a patient has got injury of radial nerve at the axilla, every motor function will be lost. That means loss of forearm extension, loss of finger and wrist extension will be lost, and sensory deficit will be there in forearm and in the fingers. If it is close to the elbow, only posterior interosseous nerve will be damaged, which is entirely motor, and it only helps with extension of the finger. So finger extension will be lost, everything else will be fine. If it is mainly at the wrist or over the forearm, then superficial radial nerve will be injured. If superficial radial nerve is injured, then only thing that will be lost is sensory function. If sensory function is lost, that means this 3.5 finger sensation will be lost only. Now, if we come back, this patient, if we see that this patient actually had not close to the distal forearm, this patient most likely had an injury below the elbow. Okay, then like a proximal portion of the forearm, and most likely he has injured his posterior interosseous nerve. Why? Because patient can do everything. There is no loss of sensation given here. The only thing patient can't do is extension of the finger, which is basically done by posterior interosseous nerve. Okay, clear? So that's how the questions come in exam. You need to know this even to understand what they're asking. Now you can choose radial nerve because posterior interosseous nerve is a branch of radial nerve. But in exam, you need to choose the best one. What is best? Radial nerve or posterior interosseous nerve? Posterior interosseous nerve, because that is the specific one. So always choose the most specific and the best option that is available. All right, so that's it for tonight. So I hope that you enjoyed the session. This is a little bit tricky for you initially, and we discussed quite a lot of complex things today, but these are very, very important. Everyone must know these topics before going for exam. And obviously throughout the course, we will discuss like this. We will have question solve classes, we will have theory classes, and hopefully you should be fine. As long as you know these topics, any questions come in the exam, you should be fine. And those of you who are already in the course, I know that many of you are already in the course. So if you are in the portal, you will find our theory lectures. So the video recordings of the theory lectures will be like all the recordings of our classes, you will get it in the video lecture option. Okay, so if you search the video lecture option by the date of the class, you should be able to find out. Okay, ideally we upload the classes in 24 to 48 hours after the class, so wait for that. And this will be uploaded to YouTube anyway as a free class, so you can also watch there. Okay. Any last date for subscription? The last date will be the end of our 2 week session. So you must have got our 2 week session, right? Let me just show it to you. So most of you are part of the first aid AMC MCQ, and we have given the 2 weeks classes schedule here. So everything is here. You can see today we have taken our question solve tips and tricks. 10th October, which means on Tuesday, we are going to start our cardiology theory classes. And then 14th and 21st of October, these two classes are recent question solve classes. This will be taken by one of our other doctor, which is Dr. Rabia, who is also very, very good and well known. So you should be able to get those mentors taking classes with you as well. Okay. And if you are planning for getting into the course, I would say start now, because we have already uploaded previous batch video recordings. We have uploaded lots of previous question discussion classes there. So you can easily just go through those questions and video recordings. You will get more and more better with those. So don't wait. If you are liking the classes, then I would just say that get into the course, get the subscription done, and get into the portal so that you can start your preparation. And the previous recorded videos are in the previous video lecture option. We will give a orientation class, Dr. Momina. So there will be a orientation session in 2 weeks time. So after this 2 week session is over, we will go through each and everything, like where to find every lectures and everything. Okay. And if anyone's status is pending, it can take at least a 1 week for us to give you the approval, because we are dealing with a lot of students right now. So if you just done the software account, then please wait a little bit. And if you have already waited for 1 week, then please send us a message or just an email that you have been waiting. Then our team should be able to approve that. And if there is any videos which are not working in the MCQ portal, there are some new videos for that. So we have deleted some previous videos. Those videos might be still in your portal. So don't worry on that. There are some new videos already uploaded in your portal. And we are still uploading new videos because there is a lot of videos. So in these 2 week sessions, we will be uploading more and more videos in your portal. So it should be fine. There is no installment in MCQ. And you will always, like, for those of you who are in the portal, you will see that there are two video options. One is video lecture and another is previous video lecture. In the previous video lecture, you will get all the previous recorded classes of our theory class. Okay, so if you're looking for theory classes, go to the previous video recording or previous video lecture. And what I'm going to do, that as I can see, you are getting a little bit difficulty to get into the portal. What you can do is that we have taken a orientation class in the previous batch, and that orientation class is already uploaded in your portal also. So what you can do is that you can also go through that orientation class. There we have discussed about how the portal works and everything. We will discuss this with you anyway in 2 weeks time. So give us that much time. But if you want to know even before 2 weeks, then go through that orientation class. We have gone through each and every part of this, like how the course works. Everything has been discussed there. So you can also just do that orientation class by yourself from the recorded lecture. Okay. All right. So we'll come again. If you have any questions, feel free to ask us in the next class. Okay. Sorry for the late finish today. We normally finish it in 2 hours time, but we just carried away today. Hopefully you enjoyed the session. Take care. Have a good night. Bye.